I suggested that the group send me the topics that you were interested in the study. Nevertheless, I didn't receive any email. So my suggestion is, for example, going over the question that have this wonderful book that is so important to complete before going to your Nclex, which is the prioritization and delegation from La Charity. There you can find um you can find the by system, no? You can find there in this book by system, and you know it's in your and you can go by system. You can have a new generation questions also there, and if you go by chapter, you know that this book is divided in the medical model by chapters now, and it's excellent. So this is what I suggest. I don't know if you want any other change. Okay, if you don't have any other suggestion, let's go over these questions. An RN is admitting a patient to the cardiac unit who has stable angina and a history of type 2 diabetes mellitus. The patient is scheduled for a cardiac catheterization the next day. So it is going to go to a cardiac cath. Which medication would need to be withheld for 24 hours before the procedure and 48 hours after the procedure. So this question is I like this question because it's very specific. It's teaching at the same time that is testing you, no? Because exactly like this, I saw one question in Nclex, exactly like this. Okay, which medication must be withhold of glucophage, glimepiride, robastatin, vitamin C in a client going to cardiac catheterism? Who knows
A. Glucophage.
the glucophage? Why?
Metformin.
Okay, because it's the same as metformin. This is a mistake. No, they should not say glucophage, should say metformin. Um, the specific reason that metformin combined with the iodine, which is the radiological contrast that is used in cardiac catheterization, produces an adverse reaction called lactic acidosis. The lactic acidosis can be lethal, can be very serious. So metformin has two contraindications. One is clients that are taking metformin has two contraindications. Clients that are going to receive iodine. In that case, the contraindication is just for a short period of time, 24 hours before the administration of iodine should be discontinued the metformin and can be restarted 48 hours after the procedure. I remember that in English is exactly those numbers were mentioned, okay? The other contraindication of the metformin is client with renal failure. So any elevation of the creatinine, which translates renal failure, would contraindicate metformin. This is the other, variation uh, 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 modality of question that I see in English. If you know that also renal failure contraindicate the use of metformin because it produces metabolic acidosis. So summarizing, let's see, is correct, okay? Should be discontinued 24 hours before, 48 after catheterization. Um, exactly. And that's it. Very good. The clinic nurse is evaluating a patient who had coronary artery stenting through the right femoral artery a week previously and is taking metoprolol clopidogrel, and aspirin. So do I understand the situation? Yes. 1 week before, the client went to a cardiac catheterization precisely, and they place a stent in one of the coronary arteries. Is taking metoprolol, a beta blocker, clopidogrel, an antiplatelet aggregation, and aspirin, also an antiplatelet aggregation medication, two antiplatelet medication. Which information reported by the patient is most important to report to the healthcare provider. We have patient is experiencing shortness of breath and fatigue. Bruising is present in the right groin. Home blood pressure is 104/52. Home radial pulse has been between 55 and 60 beats per minute. The patient is taking metoprolol. Okay. What do you think is the most serious consideration here? Let's start ruling out. Okay. Okay, let's see about the blood pressure. Is this blood pressure concerning? No, it is a normal blood pressure. Many of the students that are connecting in this moment probably have this blood pressure in this moment. It's a normal blood pressure. Okay. Meanwhile, the clients keep a blood pressure above 90/60 is considered okay stable. As far there is not an acute change. If a person usually has 130/80 and today has 90/70, it is an acute change that need to be evaluated. But in that case, no problem. So I rule out that. Okay, a bluish or purple discoloration in the groin 1 week after the catheterism. Is this concerning? No. Why? Because it's expected. Any surgery, any incision, any puncture has a little amount of blood spilled that will produce a bruise and ecchymosis. Is 1 week after the procedure the period in which we were concerned about bleeding? No. Okay, is unusual a person taking clopidogrel and aspirin at the same time? No, it's frequent. They do that to obtain the maximum antiplatelet aggregation. So you can rule out two. So you are left with the shortness of breath and fatigue presented 1 week after the procedure and a pulse 55/60. You need to know that clients taking metoprolol as far as have the pulse above 50, 50 are okay. So it's expected to have a heart rate below 60 in many of your clients taking metoprolol or any beta blockers, and the doctor will not reduce the dose unless the client is symptomatic or presents alterations in the EKG suggesting AV block, etc. But having a heart rate above 50, 50 is more than enough. So need to be one. Do you agree with the selection?
Yes.
Yes.
Okay, so let's see. Okay, they say shortness of breath fatigue may indicate anemia for gastrointestinal bleeding, which is a possible adverse of both aspirin or clopidogrel. Could be for any cause. In reality, this is not the most common cause. Whatever, the patient is not expected to be presented, okay, dyspnea and fatigue. Okay, so it is unexpected and must be reported. The patient will need to continue on the medication, but may need to be in a proton inhibitor. It is the point of view of the person who wrote this question. It's a very personal. It is one of the possibilities, but also could be another possibility like a cardiac dysfunction after the stenting. Okay, so the opinion of the person who wrote this question is that the patient could be having a GI bleeding. There is nothing that suggests GI bleeding. There is no melena. There is not a paleness. There is not. Is the interpretation of the nurse who wrote this question. But also there are other reasons for having shortness of breath and fatigue, which is not expected. By the contrary, it's expected that the clients improve. The main concern in this client is that the stenting the stenting is not working. So the heart is not working properly, producing the cerebral fatigue. But it's okay. It's another possibility. Let's see. Which topics will the nurse plan to include in this chart teaching for a patient who had been admitted with heart failure? Okay, interesting what you teach. This is a very common type of question in English that apply of basic teaching. What is the teaching? Let's see. How to monitor and record daily weight. I hope that you say yes, because
Yes.
daily weight is the best parameter to decide if the client is retaining fluid, which is the first step in the decompensation of heart failure. We are talking about heart failure. Importance of stopping exercise if heart rate increases. I don't agree with that. It is expected, it is expected in everybody that if you are exercising, your heart rate must increase. There is always a limit to that, but it's not stated here. So there is a limit, okay, to the the amount of increment of the heart rate, okay, of the client. But it's not so you don't stop exercising because your heart rate increases. This is a wrong statement. I teach symptoms of worsening heart failure, of course, because it's another thing that they need to recognize: edema, excessive dyspnea, even at rest, intolerance to the flat position, weight gain, etc. Purpose of chronic antibiotic therapy. We don't use antibiotic in heart failure, so it is a stupid, very, very easy distractor. How to read food labels for sodium content? Yes, because they should have a restricted sodium diet. Date and time for follow-up appointments, of course. Okay, an easy one. As usually in English, the set that applies are very easy questions. And remember that now they give you partial credit. The nurse is reviewing the lab result for a patient with an elevated cholesterol level, high cholesterol, who is taking atorvastatin and statin. The purpose of the atorvastatin is to decrease cholesterol. The side effects are hepatotoxicity and rhabdomyolysis, but are very rare. The hepatotoxicity is monitored with the AST-ALT, and the rhabdomyolysis is preceded by muscle pain and elevation of the CK. Which result is most important to discuss with the healthcare provider? Be aware that those questions that say most important are difficult, are not easy, because everything here could be important, could be important. So it is a prioritization question, and those questions are difficult. They report a serum potassium of 3.4 milliequivalent per liter, based in our normal values is 3.5 to 5, but they are giving here normal values. Okay, 3.4. BUN 9. The BUN is normal. The BUN is 10 to 20. So having a low BUN is not problem. Having a high BUN is problem. Low BUN is found in people that are, for example, vegans, okay? That, they restrict their consume of meat. High BUN can be found in renal failure or in dehydration. So this BUN is not concerning. The AST-ALT. The AST-ALT should be below 35, 40. So this is a normal AST-ALT. And the LDL is 170. LDL should be below 100. So based on those normal values that I gave you, which one is the one that we need to report? So obviously it's not BUN. is not AST because AST is normal. Okay, remember 40, 40, 45 as the limit. Yeah. And of both AST and ALT. You don't need to memorize exactly the number value. A party that now is giving in the test. But here it is a you know a distraction here. So you have in reality those are the normal values, are the values in millimoles, okay? So you have a potassium in 3.4 and you have an LDL in 170. What do you think? What is your opinion? Is between those two?
Number 4.
Number 4.
Okay, I agree. This is a very high LDL, to be below 100. So the medication is not working. It's not working. Okay, so let's see. Correct. The patient's LDL level continues to be elevated and indicates a need further assessment. For example, the patient could not be taking the atorvastatin, a change medication, or both. Although statin medication may can rhabdomyolysis, we could increase BUN and potassium. The patient BUN and potassium are not elevated. Although ongoing monitoring of liver function is recommended, the AST is normal. Absolutely. Good. We finding in the patient with aortic stenosis will be most important for the nurse to report to the healthcare provider. Aortic stenosis means that the aortic valve is too narrow. Remember that the left ventricle ejects the blood in the aorta when the aortic valve opens. When it is too narrow, is one of the most common alterations in the valve, the aortic stenosis, very common in older people. The left ventricle need to do has an overload of work and tends to dilate, producing left heart failure. The aortic stenosis associated with left heart failure also can produce angina, also can produce syncope because the lack of flow to the brain. And yes, those are the consequences of aortic stenosis. Okay, the left heart failure, angina, and syncope. So this is a patient with aortic stenosis. And they are asking, most important for the nurse to report to the healthcare provider. We have a client with fever, a client with a systolic murmur over sternum. Remember that the aortic valve is better auscultated in the second intercostal space at the right of the sternum. Blood pressure 110/88. We can rule out this. Weak radial and pedal pulses to palpation. So the pulses are weak. What do you think?
Professor, I would say number 4.
Number
Go.
4. Okay. Remember, I cannot draw here. Remember that if just a second. Remember that if I have these weak these just a moment. Okay. Okay, if we have these very narrow, okay, very narrow aortic valve, then the volume of blood that is moved to the extremities is decreased, and the left ventricle it has decreased function, is dilated, and the amount of blood that is sent to the arms and the amount of blood that is sent to the legs is decreased. Notice that the pulses are classified 0, 1, 2, 3, and 4 plus. Okay. Plus being 1 plus weak, but they say that is equally weak in the upper extremities than in the lower extremities. My question is, the client has pulse and is decreased, but is not, is decreased, but is there have pulse, and is the same amount of reduction in the upper and lower extremities. Is not expected this finding in this condition. So it could be a manifestation of the own disease. So could be an unexpected unexpected finding. So let's consider other options. Okay, yeah. Let's consider another option. So the blood pressure is acceptable. The fact that the radial and pedal pulse, so arm and leg pulses, are weak. Okay, 1 plus, for example, because 1 plus is weak, which is expected. Is the murmur expected? Yes. You in those alterations of the valve, you expect a murmur. So what is not expected is a fever. Fever is not part of this condition that is is a chronic condition. The client has aortic stenosis for years, and it's not expected fever. But we should know that there is a disease, a cardiovascular disease that is important to note. It's called bacterial endocarditis. And we should know that bacterial endocarditis usually occurs in people with previous valve damage, mitral or aortic. Valve problems, okay, murmurs, because problems in the valve are the 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 past history that more frequently have a client with bacterial endocarditis. So it's the most concerning here, the unexpected in a client with aortic stenosis in this question, that should guide the nurse to rule out, not necessarily is an endocarditis, but should guide the nurse to rule out bacterial endocarditis, the presence of fever, which is not expected. The murmur, the blood pressure is normal, and the weak pulses are expected in aortic stenosis, but no fever. So that's why I think that you should rule out a bacterial endocarditis. Okay, because endocarditis is a concern with valvular disease and elevated temperature indicate need for further assessment and diagnostic testing, like an echocardiograms and blood cultures. Okay, here is another learning that has been tested in Nclex. How you diagnose, how you expect to be diagnosed endocarditis. You expect doctors to order blood culture. Who is going to take the blood? The nurse could be ordered to take the blood. So you need to take three specimens of blood from different veins, okay, and send that to the lab to be cultured. If there is an endocarditis in the blood that is passing through the aorta, will have bacteria and will grow in the culture. And the echocardiograms will evaluate the severity of the narrowing of the aortic valve and also the presence of the vegetations that are like clots of fibrin that grow in the surface of the damaged valve that get infected. A murmur because pulse pressure will pulses are expected in patients with aortic stenosis and would not indicate immediate need for further evaluation and treatment. Remember that the aortic stenosis is a chronic condition that starts, okay, mild, progress to moderate, and then reaches severe levels of narrowing that requires surgery. The doctors have specific criteria to decide when the aortic stenosis requires surgery. The surgery is a replacement, decay of the valve, a valve replacement. So the natural valve of the individual that has become too narrow is removed, and a new valve is placed instead. Those new valve can be two types. Another English question. Mechanical, when they say mechanical, okay, mechanics are valves that are made with metal and plastics. Those valves are very efficient, are lifelong lasting, so doesn't need to be replaced, but have a defect. They tends to produce clots. A clot produced in the aorta will produce a stroke, embolization on the legs, etc. So those clients need to take lifelong, the rest of their life, on anticoagulants. They are going to be taking warfarin the rest of their life. Another type of valve replacement that they can use is biological. It's not mechanical, but biological, natural. They take valve from pigs. The pig hearts are in size and morphology very similar to to humans, and for that reason, they usually use pig hearts to obtain the valve to use the replacement. These biological valve replacement from pigs are very good because they don't produce clots. They don't require anticoagulant. And the bad part is that they last less than the mechanical. So every certain number of years or 1 decade more or more need to be replaced. Uh, this question is in English. What is the main difference between mechanical and biological valve, and is the use of anticoagulants necessary in mechanical, not necessary in biological? But don't forget bacterial endocarditis. Bacterial endocarditis generally occurs in people with previous cardiac damage, murmurs because valve malformations or problems or abnormal holes like ventricular septal defects, etc., etc. So this is a learning from this question. Absolutely, it's a way of learning cardiovascular with a question. A patient who has just arrived in the emergency department reports substernal and left arm discomfort that has been going on for about 3 hours. Which laboratory test will be most useful? Most useful is superlative in determining whether the nurse should anticipate implementing the acute coronary syndrome standard protocol. And they are giving us the creatinine kinase MB, troponin I level, myoglobin level, C-reactive proteins. You know that the answer is troponin. No?
Two.
Troponin. Troponin is the most specific for that. Nevertheless, after 3 hours, maybe the troponin is still not elevated. Not all clients have a rapid elevation of the troponin. That's why doctors order to repeat, a series of the determination to be sure if the client is having necrosis or not. Don't forget that any pains suggestive of angina like this one should be treated like an acute coronary syndrome. You don't need to wait for the elevation of troponin. So in some way this question is a little misguiding. Okay, this nurse doesn't need to wait for the troponin to implement the acute coronary syndrome standard protocol. All those clients that are admitted with chest pains are, admitted with the acute coronary syndrome standard protocol. The main purpose, the number one, is to eliminate the pain. The first step is nitroglycerin. If nitroglycerin doesn't work, is not removing the pain, then morphine is added. But the pain should be, be zero. zero pain. The administration of aspirin is another standard of the protocol because aspirin chewing a 325 from 81 to 325 milligrams of aspirin has demonstrated decreased mortality. The electrocardiogram EKG should be the first test to be done because in case of myocardial infarction, can show the myocardial infarction since the beginning. You don't need to wait too much. And then, of course, the blood specimen for troponin. But a normal troponin not necessarily rule out KMI because at 3 hours because could elevate later. Usually they are observed for more times and they repeat more troponyms. It's important. Yes. Those clients need to be monitored because the most common cause of complication is cardiac dysrhythmia. What else? Okay. Yes, this is important. Clients that the pain doesn't improve with morphine need to go to cardiac catheterization, emergency cardiac catheterization. What else? Well, it's not the most important that come to my mind in this moment. An important detail that I wanted to say. Remember that if the client is having angina, that could be an unstable angina, the troponin does not elevate. The troponin elevate only when there is myocardial infarction. So also client with angina, for example, unstable angina, a change of pattern of angina are critical clients that may be required, catheterism and acute coronary syndrome standard protocol. So not necessarily the elevation of troponin make the clients critical. Yeah. A client with chest pain that appears at rest, for example, or with minimum effort, or a chest pain that has is difficult to eliminate with the nitroglycerin, could require a cardiac catheterization. So the nowadays is not necessarily waiting until the client is having a myocardial infarction with elevation of troponin to consider the client as delicate and requiring the acute coronary syndrome standard protocol. So that's why I wanted to clarify that, because in some way this question could misguide nurses that you need to wait for the troponin elevation to consider the client's acute coronary syndrome. No, angina is also an acute coronary syndrome. Okay, you never know what is going to happen with those clients. Creatine kinase hemoglobin also increase, but creatine kinase takes 6 hours to increase. Okay, and it's not a specific elevated reactive. It's not has nothing to do. Okay. Okay. So this is what you can learn from this question for thinking always in your anchors. When the nurse is monitoring a 53-year-old patient who is undergoing a treadmill stress test. You know what is that? No? The running in the treadmill stress test while doing an EKG. Inclined with history of chest pain to clarify the pain is ischemic, is it angina or not, which finding will require the most immediate action. I noticed there is a lot of prioritization question here. So blood pressure is elevated, uh, mildly elevated, heart rate increase, oxygen saturation is a little decreased, not critical, but a little decreased, and 3 PVCs in a row. What do you think, guys?
The oxygen. Oxygen is
Okay,
low.
so it's important to know that normally, when we are exercising, there is a drop in the oxygen saturation because we use more oxygen. It's like money. When you could be making a lot of money, but if you have too much expenses, you know, you are always short of money, no matter that you are making a lot of money. Yes. and the same happens with the oxygen. Even if you have a normal capacity of oxygenating, if you are exercising, there is a expected drop in the O2 saturation, and it's not critical. Okay, consider critical below 90, guys. So for best strategies, okay, generally the drop of oxygenation is critical below 90. Okay, so I don't think it's going to be the. Also expect an increment of the heart rate when a client is exercising, and activation of the sympathetic nervous system, and a mild elevation of the blood pressure. What is not expected is to have PVCs, 3 together, one after the other. This is a mini VTAC, a mini ventricular tachycardia. You know, it's a it's a it's, it's a it's a it's a run. It's a run. It's called run. VTAC run. You know, self-limited, but remember that in client with ischemia, the client is having a stress test because it's suspected to have ischemia, a myocardial ischemia. The age is compatible with this diagnosis, and having PVCs frequent um, in group, so pairs or in triplets like this, or with the phenomenon, the R on T. I don't know if you are knowledgeable about that, but it's something that you should know. Okay, you should know. The the EKG, okay, usually have, okay, a PQRST, which is the normal stuff, but suddenly you can have, okay, a monster that comes without P wave, and uh, a little too soon. Let me make it a little sooner. Okay, a little too soon. Uh, um, um, Near. Okay, let me make the monster here. Near. Okay, near. Okay, the previous normal bit. And in that case, they say that the client had, okay, a run of 3 PVCs together. 3 PVCs together. You understand? So when you have frequent PVCs in ischemic client, they come more than one, okay, in duplex, okay, in pairs or triplets like this, or they are falling too near, okay, too near the T or the previous QRS. The phenomenon, the R on T, is called R on T phenomenon. Those in clients with ischemia, those are criteria of severity. Remember that one PVC in an ischemic client can trigger a VTAC, or a ventricular fibrillation. Remember that with VTAC, at least in 90% of the cases, and ventricular fibrillation, the patient is dead. The patient is dead. Okay, the patient is dead. Okay, is dead. Okay, is dead. So that's why in these questions, no doubt that the priority during a exercise in ischemic client, ¿dónde estoy aquí? ¿Cómo se llama? Stress test, these EBCs are very, very extremely concerning. Extremely concerning. 3 PVCs is in a row indicate non-sustained ventricular tachycardia, and are an indication to stop the testing to avoid worsening dysrhythmia. Moderate elevation in blood pressure, heart rate, and a slight decrease in oxygen saturations are a normal response to exercise in any of us. Okay, in any of us. Okay, so another learning okay, from this question. The healthcare provider prescribed this action for a patient who had a meeting with acute substernal chest pain, another ischemic pain, which actions are appropriate to assign to an experienced LPN who is working in the ER. So that apply. Okay, attaching cardiac monitor leads. Yes, an LPN should know how to do an EKG, how to attach the cardiac monitor leads, etc. LPN knows how to do that. I hope that you know how to do it. It's very embarrassing when an LPN knows more than the RN. I studied in this city, LPN in a vocational school, Robert Morgan, and then I studied for RN in FIU. And I can assure you that they taught me a lot of more practical, okay, stuff in the Robert Morgan than in the FIU. Usually it happens. Giving heparin 5,000 units IV push. IV push should not be delegated, should not be delegated to the LPN. No IV push. Administering morphine sulfate 4 milligrams IV is the same as another IV push. No. Obtaining an EKG, yes. Asking the patient about pertinent medical history. No, this is initial assessment. They can do assessment, but ongoing assessment. So then tomorrow, when the LPN comes to give medication to this client, she can ask the client, how you feeling? Have you been experiencing pain when you go to the bathroom? Have you been dizzy? Okay, let me assess your lungs. Let me count your apical pulse. LPNs can do ongoing assessment. But this is the initial assessment in the ER, okay, and the patient is arriving, that will make or decide, okay, the what to do with this client. Yeah. So this is initial assessment. No, initial assessment not. This is not an ongoing assessment. They cannot be delegated to the LPM. Having the patient chew and swallow aspirin, yes. Okay. Correct. Attaching cardiac monitor, tuning and EKG, administering oral medication with discovered practice LPN and experienced LPN will be familiar with these activities. Although anticoagulants and narcotics may be administered by the LPN to stable patients, these are high alert medication that should be given by the RN and stable patient. And remember, no IV push. Obtaining a pertinent medical history requires RN level of education and scope of practice. Based on this information in a patient medical record, which topic is the highest priority for it is a redundance, but I love redundance, for the nurse to include in the initial teaching plan. So it needs to be the RN. For a 26-year-old patient who's very young, who has blood pressure ranging from 150/84 to a 62 now, so has hypertension. It's a young person with hypertension that requires initial teaching. Health history denies any chronic health problems, takes no medication currently. Physical exam, high body mass index is okay, is not obese, has a normal weight. Social and diet history, works as an accountant. It's not a very stressing work. Nursing is more stressing than accountant. They are stressed only when the taxes in the period in April, when everybody procrastinated and did the taxes for the last moment. And then they have a lot of clients, okay, pushing to have their taxes done. Okay, one glass of wine once or twice weekly is okay. This amount of alcohol is not. Eat fast food frequently. Fast food is McDonald's, no, and similar, no, that is not good for hypertension because high cholesterol, high salt content, etc., etc. Okay, so let's see. Only one because it's multiple choice. Symptoms of acute stroke and myocardial infarction is not usual at this age. at this age is not unusual. Okay, expected. So I can rule out this. Adverse effect of alcohol on blood pressure. It's okay, but the client is just not abusing of alcohol. That's why it's not addressing the client. Method of decreasing dietary caloric intake. The guy is not obese. The guy is, by the contrary, is thin. Is a thin client, 18 BMI. And low sodium food choices when eating out. Of course, this must be the option. Current guidelines recommend low sodium intake for lifestyle management of hypertension, and the nurse should teach a patient about high sodium content in many food, how to make healthy choices. 26 with this hypertension is not uh, uh, propense to have myocardial infarction or stroke. Weight loss or changing alcohol intake, they are not necessary in him. The patient BMI is normal. Alcohol take is okay, so no problem with this question, not too much teaching. The nurse makes a home visit to evaluate a hypertensive patient who has been taking enalapril, a ACE inhibitor, which finding is most important to report to the healthcare provider. Patient reported frequent urination. No related with the enalapril. Patient blood pressure is, well, is not perfect, but is acceptable. Patient complains about frequent dry cough, the classical question. Patient says, I get dizzy sometimes if I stand up fast. What is the solution of that? Don't stand fast. So this is a common question in English. Okay, those are the type of questions you cannot fail in English. Okay, when you teach a client that is taking for first time a medication for blood pressure, and there's the you know, change position slowly because it's expected to become dizzy if you stand fast. So obviously the answer is 3, because this dry cough is cannot be tolerated. Is nocturnal, doesn't allow you to sleep. Is continuous, doesn't allow you to speak, to be in, you know, in a quiet place. So it's unacceptable, need to be reported, and the medication should be changed. Persistent and return cough caused by accumulation of bradykinin is true. This is the substance that accumulate in some people, not everybody, in clients taking ACE inhibitors. The bradykinin is a possible adverse effect of angiotensin converting enzyme inhibitor. This accumulation of bradykinin in some people is so severe that produces angioedema, and they swell the lips, the tongue, and the throat, and can have airway obstruction. Don't forget that the vocal cords are also swollen. If this unexpected, idiosyncratic, bad luck reaction occurs, the same as the cough, you cannot anticipate who is going to develop cough and who doesn't. It's something that happens in some people and doesn't happen in others. Okay, so it is just bad luck. So angioedema, okay, is also related with this bradykinin accumulation. It's unpredictable. It's not dose related. It's not related with anything. Okay, so if the client is having the cough, need to report, and even the first dosage, you need to monitor for angioedema. We're changing the other medications, so angiotensin II receptor blockers. This is the ARBs. Yes, the sartan, no? Low sartan, ibersartan, valsartan, that don't produce the cough. They do the same practically than the ACE inhibitor, but they don't produce cough. The other assessment data indicating for more teaching, ongoing monitoring, but no, okay, no need of change of therapy. Very good. While reviewing a hospitalized patient medical record, the nurse obtains the information about cardiovascular risk factors, which interventions will be important to include in the discharge plan for these patients that apply. Health history, hypertension, 10 years, take hydrochlorothiazide, which is good for hypertension, 25 milligrams daily. It is a diuretic, a thiazide. Okay. Family history: patient's mother and 2 siblings had myocardial infarction. It is not good for the client because it's a family history of ischemic heart disease, so has increased risk because the family history. And it is added to the hypertension. They don't say the age or the gender. Social history: 20-pack year history of cigarette use. Okay, so the guy has been smoking 1 pack of cigarettes for 20 years. It is another risk factor. Walks 2 to 3 miles daily. It is protective. It is good. So what need to be modified in this patient? Referral to a community program that assists in smoking cessation? Yes. Teaching about the impact of family history on cardiovascular history? Yes, because it increases the client's risk. That's why this client need to be especially, more than usual, especially enhanced, careful with the risk factors, because genetics is not in his or her favor. Education about the need for a change in antihypertensive therapy. Why? You don't need to change the hypertensive therapy. Assistance in reducing emotional stress. What do you think?
Yes.
Okay. Discussion of the risk associated with having a sedentary life. What do you think?
No, doesn't he
No,
walk?
because it doesn't apply to the client. The client is walking a lot every day. So it's not sedentary. Teaching about the signs of hypokalemia and food to supplement potassium loss. Yes, guys, is taking hydrochlorothiazide. Okay, they say that is incorrect. Okay, this is incorrect because we click assistant in reducing emotional stress. It is a trap in many Nclex questions. The patient's major modifiable risk factor is ongoing smoking. The family history is significant, and the patient should be aware of this, increase his or her cardiovascular risk. The blood pressure is well controlled on the medication and doesn't need to be changed. There is no indication that stress is a risk factor in this client. Okay, it is a trap. It is not knowledge. It's just the traps that nursing test, especially banks and professors questions in test have, and you need to learn. You need to learn how to survive that thing. You need to know how to survive your test. So it's a trap because this is true. In any moment here, they said that the client is under stress. But it's unfair. This kind of question, I am not used to see this kind of tricky traps in Nclex. I think by the information that I've been collecting along years about Nclex, the Nclex doesn't do that. Nclex, it's a misguide because everybody knows that it's good for people with hypertension to reduce stress. You can teach people to practice, meditation, yoga, tai chi, whatever. Okay, the machine. Okay, so it is a trap. But guys, learn, develop the skills to recognize when they want to get you. Okay, in a test. Not so much in English, but in English. There is an indication that in this patient, the patient activity level meets the American Heart Association recommendation of at least 150 minutes of moderate activity weekly. American Heart Association said 3 to 5 days 3 to 5 days doing a 30 minutes exercise. Hydrochlorothiazide can deplete potassium. Muscle weakness and cramping are signs of hypokalemia. Banana. So Nclex love cramping in a client as a manifestation of low potassium. Don't forget that. Cramping is this pain that you experience in your legs Okay, okay, and that's it. Banana, yogurt, spinach, and avocados are some food that are high in potassium. Maybe you don't know that milk and dairy are rich in potassium and sodium. So milk and dairy, like yogurt, cheese, etc., are high sodium milk and high potassium food. Okay, this is for some of us. It is something that we are not aware. Everybody know that avocado and spinach, green vegetables and banana are rich in potassium, but this is always a learning that could help in another question. Which patient is best for the coronary care charge nurse to assign to a floating RN? Floating RN that is coming for the day from the general medical surgical unit. So a nurse of med-surg is floating to the coronary unit. It's a little more specialized, okay, place. Remember that the rules are: one, give an stable client, give a client that is, let's see, easy. And second, that what need to be done to this client can be done by the floating RN. So we have patient requiring discharge teaching about coronary artery stenting before going home today. Okay, teaching about stenting is a very specialized stuff that should be done by the nurses of the coronary unit. Rule out, discard this. Patient receiving IV furosemide to treat acute left ventricular failure. Left heart failure, IV furosemide. Could be a patient who just transferred in from the radiology department after angioplasty. Remember that those just admitted, just transferred are unstable clients, are Pandora boxes. We don't know what they are bringing. And this client has an angioplasty, an invasive procedure where a balloon was inflated in the coronary artery after a cardiac catheterization. Very unstable and delicate client. No, no. Patient just admitted with unstable angina. Now, only with this is a no-no. Who has ordered for a heparin infusion, so IV heparin infusion, which is a complicated therapy, and aspirin. So the least acute are 2 and 4, and from 2 and 4, the least acute is 2. Do you agree with me? Yes or not?
Yes.
Yeah.
Everybody,
Yep.
guys, you can argue with me. Okay, I can be wrong. Let's see. Okay, also we can see with La Charity, an RN who work on the medical surgery unit with a familiar with left ventricular failure, so heart failure, and administration of IV medication, of course. The others are a little more specialized. Okay. At 9 p.m., the nurse admits is wearing the test. They use 12 más 9, 20, at 21, the nurse admits a 63 years old patient with a diagnosis of acute myocardial infarction. Which finding is most important to communicate to the healthcare provider who is considering the use of fibrinolytic therapy, alteplase, with tissue plasmid activator alteplase for the patient. The patient was treated with alteplase 8 months ago. The patient takes famotidine for GERD, gastroesophageal reflux disease. The patient has ST segment elevation in the electrocardiogram. The patient reports having continuous chest pain since 8 a.m. What is the answer, guys?
Number 4.
Why number 4?
Because in order to give the alteplase, it's time sensitive. So
Correct. And the patient has already has 21 minus 8 is going to be like 14 hours with pain. And beyond, okay, 6 to 10 hours, there is no benefit in administering okay, the TPA, there is no benefit in this patient, okay, and it's at 13 hours, 13 hours of pain. So I agree with you, totally correct, and you are correct. Okay. Um, the Food and Drug Administration establishes that the alteplase is useful and has been approved to be used before 6 hours of the initial pain has passed. Nowadays, the American Heart Association and all the organizations that investigate have extended this time frame to 10 to 12 hours. Okay, but beyond 10 to 12 hours, there is no benefit. This patient has 13 hours. Okay? The nurse is caring for a patient who has heart failure and a new prescription for sacubitril valsartan. Okay, this is a combination of anti-renin and an angiotensin receptor blockers, sartan. Which patient information is most important to discuss with the healthcare provider before administering this medication to the client? So the nurse is going to administer the medication and find something that requires clarification. Patient O2 saturation is 92%. It is not contraindication. This is no contraindication. Patient received lisinopril, 10 milligrams daily. The patient blood pressure is 150 over 90. There's no contraindication. The patient potassium is low, 3.3 milliequivalents. Okay, guys, between 2 and 4, what do you think?
Or
Okay, what do you expect
No, 2.
to happen? What do you expect to happen when an ACE inhibitor or a ARB is given with the potassium? You expect to increase, not to decrease. So this potassium is low, but what happens when this kind of medication is given? This kind of medication elevates, raise, okay, the potassium. So it is a trick, another trick there to say potassium first, potassium first, potassium first. So yes, you're right, 2, because lisinopril is doing the same as sacubitril and valsartan.
Can mix
Cannot be
because have the
mixed.
same
The same action.
mechanism. Of
So it's a redundance. Let's see. It's a redundance. So maybe the doctor didn't know that. Okay, they said correct. Because combination angiotensin receptor blocker, neprilysin blockers, okay, markedly increase the risk of angioedema in patients who are also taking angiotensin converting enzyme inhibitors. The concomitant use of both lisinopril and sacubitril valsartan is contraindicated. In addition, the risk for other adverse effects of hyperkalemia, hypotension are increased. The other findings should be reported to the healthcare provider, but not indicate need of withhold the sacubitril valsartan. So remember, valsartan, losartan, irbesartans are ARBs, angiotensin receptor blockers, that are doing exactly the same as lisinopril through different ways, but at the end they are decreasing angiotensin too. ¿Cómo se llama? De neprilysin, lysine is blockers are blocking the action of the renin, which is also doing the same. So it could be a redundance. They said something that I really didn't know exactly, that when you combine this kind of medication with ACE client taking ACE inhibitor, also the risk of angioedema that we already talked is increased. So we are learning something from this. But they reinforce our initial opinion that is a redundance that is going to produce unnecessary side effects like hyperkalemia, hypotension, etc., because it's a redundance. A patient whose systolic blood pressure is always higher than 140 in the clinic tells the nurse, my blood pressure at home is always fine. It happens sometimes to me that I check my blood pressure at home frequently, and it's totally normal, even a little low. And when I go to the doctors, the first time that the nurse takes the blood pressure is a little high. Is what is called the white coat reaction. It's a psychological reaction. Okay, and then I tell the nurse, okay, wait a minute, wait 2 minutes, take it again, and when the nurse takes the blood pressure again, it's normal. You see that I know my okay, but it is possible. But now, is the client, the patient is the one that is saying the nurse, my blood pressure at home is always fine. But when you take the blood pressure, each time the client comes is high. So the question is how you should nurse do next. Instruct the patient about the effects of untreated high blood pressure on the cardiovascular and cerebrovascular system. Okay, it is okay. You can teach that, but it's not addressing the question. The problem in the question is that the fact of your evaluation of the blood pressure is high, while the patient assures that at home the blood pressure is normal. So it is a contradiction there needed to be clarified. So I need assessment, not teaching. Educate the patient about lifestyle changes as low sodium diet, daily exercise, and restricting alcohol use. Blah, blah, blah. It's the same situation, the same education. 1 and 2 rule out each other because it's the same. This is teaching and this is teaching. Ask the patient to obtain blood pressure twice daily with an automatic blood pressure cuff at home and bring the result to the clinic in a week. I like it. I like it because the automatic blood pressure devices have memory and they can store the values in the memory. Provide the patient is an assessment. It is an assessment. Provide the patient with a handout describing the various type of hypertensive medication and other teaching. So 1, 2, and 4 are teachings, okay, that are not addressing the problem. The discordance between home and your findings. So the best option, of course, need to be 3. Do you agree with me?
Yes.
Yes, Professor.
Of course. Yes. The nurse is working with an experienced assisted personnel, CNA, and LPMs on the telemetry unit. A patient who had an acute myocardial infarction 3 days ago, 3 days MI, has been reporting fatigue and chest discomfort when ambulating. Which nursing activity included in the care plan is best assigned to the LPM? Let's see. Administering nitroglycerin 0.4 sublingual if chest discomfort occurs during patient activity, it is okay. It is in the scope of an LPM to administer PRN, sublingual or oral or intramuscular or subcutaneous medication. So nitro is a PRN for chest discomfort and can be administered by the LPM. Can the LPN take the blood pressure? Yes, etc., etc. Taking pulse, blood pressure, and oxygen saturation before and after patient ambulation. Okay. If the patient is presenting those symptoms, this ambulation should be done by the RN, not by the AP. The RN could delegate to the AP, to the nurse assistant, to take the blood pressure, the pulse, and the oxygen saturation, okay, while the nurse is doing other assessment. But doesn't necessarily need to be the LPN. I preferred one. Teaching the patient energy conservation techniques to decrease myocardial oxygen demand. This is an initial teaching. So this is a no-no. Explaining the rationale for alternating rest periods with exercise to the patient and family is the same teaching. So 3 and 4 rule out each other because it's the same. 3 and 4 is the same, so cannot be the answer. So the best option is 1. Do you agree with me?
Yes.
Yes, assuming that. Okay, correct. Administration of nitroglycerin and appropriate patient monitoring of therapeutic side effects, including LPA, evaluation of scope practice, taking blood pressure. Let's see how they solve the problem of the blood pressure. Taking blood pressure post saturation should be delegated to the nurse assistant. Patient teaching requires RN level education. Okay. More or less the same criteria. The emergency department nurse is caring for a patient who has just admitted with left anterior chest pain, suggesting possible acute myocardial infarction. Which action will the nurse take first? So the patient is just admitted with pain, suggesting MI. Okay, insert an IV catheter, auscultate heart sounds, administer sublingual nitroglycerin, draw blood for troponin. What you do first?
Nitroglycerin.
Yes, I agree with you. This
Nitroglycerin.
is the first that you need to do. Yeah, absolutely. 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 The first to do because the patient is having pain. The priority is to eliminate the pain. And then you go to the others. Okay.
Then you take care of the IB and the rest.
Yeah. The priority for a nurse patient with unstable angina or MI is treatment of pain. It is important to remember to assess vital signs before administering the sublingual nitro. That's why I wasn't reading to blood pressure. No, they didn't mention blood pressure. The other activities also should be accomplished rapidly, but are not high priority. Remember that before giving nitro, I need to ask the client if is taking any afil, sildenafil, tadalafil, badnalafil, any afil or erectile dysfunction medication. And I should take the blood pressure. Okay, if the blood pressure, the systolic, is below 90, I need to withhold the nitroglycerin and report that. Yeah. So the contraindication for nitro, that the patient is taking erectile dysfunction medication or the systolic blood pressure less than 90. That's it. I was
Professor, in that
yes, yes,
case,
yes.
if is taking is the blood pressure is high,
Uh,
what do you do?
you give it. It will lower the blood pressure. You give
Oh,
it.
if it's lower,
If it is less than 90, you withhold and report me to the doctor because it's a cardiogenic shock probably.
oh, okay.
Don't give nitro if the blood pressure, systolic blood pressure is less than 90, or if the client is taking erectile dysfunction medication that ends in AFIL, afil.
Okay.
Those are the two to remember, the two very precise detail to know the contraindication. So I was, after the answer, I mean, nitro was double checking that maybe this is same blood pressure in some place, because if they put here blood pressure, take blood pressure, you first take blood pressure and second give the nitroglycerin, because it's suspected that you don't give the nitroglycerin to a client that have hypotension. An 80 years old patient on the coronary step down unit tells the nurse, I do not need to take that docusate. Docusate, calcium docusate, is an stool softener that is a routine in patient with MI. I never get constipated. Which action, it is a very common scenario. Which action by the nurse is most appropriate? Document the medication on the patient chart as refused. Remember that before documenting, you need first find the reasons for which the client is refusing the medication. In this case, the client already told you why. Is that trying to say, I never been constipated. I'm very regular. I don't need to take it. So it's giving you the why. So you know that the problem is a knowledge deficit. because the circumstances around an MI will produce in the client for first time in his or her life constipation, because the morphine produces constipation, the qué sé yo, the beta blockers produce constipation, many the type of diet produce constipation, the rest produce constipation. So usually patients in ¿cómo se llama? In coronary, well, hospitalized in general, they develop constipation. You don't expect in MI for the constipation to develop to initiate the stool softener. Why? Because then those clients need to strain, push, bear down, no? Do valsalva to poo. And this can produce a severe vasovagal reaction, bradycardia, AV block, ¿cómo se llama? Extension of the size of the infarction, the cardiac dysrhythmia, ventricular fibrillation, and a lot of problems. Okay, so this is a common scenario. So why the most important that you do document that the patient refuse the medication? No, because you first need to assess why. And second, make the client aware of why the medication is needed. Mix the medication with food and administer heating. You cannot do that. It is illegal. Okay, it is illegal. Okay, totally illegal. You cannot do that. Okay, even if you saw that in nursing homes in rotation, don't do that in the test. It is illegal. Okay, it's an ethical violation. So you are there doing a veracity violation, basically veracity violation, because it's not anything else. And also violation of the autonomy of the client. Okay, and from the legal point of view, doing that is battery. Okay, is battery, because you are touching a client, giving the medication hidden in the foot without the client consent. So don't do that. Explain that his decreased activity level may cause constipation. This is the answer. Reinforce that the doctor said has been prescribed for good reason. No, it is not an explanation. Let's see, of course. Let's see what else saying about status, chart and medication refusal. Okay, yeah, the same that we said. Okay. The nurse has given morphine sulfate 4 milligrams IV to a patient who is having an acute myocardial infarction. Okay, morphine. Obviously, probably the client received the nitroglycerin. The nitroglycerin was not enough to take the pain away, and is receiving morphine. When evaluating the client's response 5 minutes after giving the medication, which finding indicate the need of immediate further action 5 minutes after giving the morphine. Blood pressure decreases from 114/65 to 106/58. Respiratory rate dropped from 18 to 12. Cardiac monitor indicating sign of rhythm at a rate of 96. Persistent chest pain at the level of 1 on a scale 0 to 10. What is your answer, guys?
2.
2. Why 2? It is normal.
Professor, I have a question because
Sure.
2 is in the normal range. For me, it's
It's normal. For you, is what?
1.
1. The blood pressure too low. I insist also morphine is a vasodilator. You expect a drop in the blood pressure, and that's why when we give morphine, we keep the client on bed. It can be a nurse Nclex question. As a fact, was an Nclex question. That what was doing wrong, the CNA in a client receiving patient control analgesia with morphine, and was helping the client to ambulate to the bathroom. Clients receiving IV morphine cannot go to the bathroom, need to do in the on bed, because the opioids, especially when administered IV, produce a drop of the blood pressure. So it also, well, so 12 is normal, and this blood pressure is normal. So I think that this question is tricky.
Yeah, that's kind of tricky because the drop is it's high from 18 to 12, but it still is within the normal range.
Yes, and the
However,
drop has
the press
been nine, no? A ver,
and the blood pressure is not
yes,
normal. I
nine,
mean, it's
nine, not eight millimeters of mercury only.
uh
Okay, the respiratory rate is normal. 12 is normal. You expect that the morphine will sedate the client and will decrease the respiratory rate. Of course, that yes, but not below normal. So that's the tricky part. You expect that the morphine will drop the blood pressure, but not below normal. You expect that the morphine will sedate decline and will drop the respiratory rate, but not below the normal, especially if the pain is removed. Remember that the pain elevates blood pressure and elevates respiratory rate. So expect those changes, but not below normal. And those are normal. So there is a bad intention in this question. Having a sinus rhythm is good. And 96 is still considered normal. So probably the trap is here. In reality, guys, you need to learn that the purpose of management of pain in myocardial infarction, not in other kind of pain. So in let's see, I have, I don't know, a burn, and you give me the morphine and my pain is 2 or 3, it's okay. It's a good outcome. Reducing a pain that was in 10, as usually is the pain in burns or kidney stones, etc. Reducing that to 2 or 3 is is a gain. Yeah, it's a good outcome. But in the case, remember that of chest pain, because ischemia, heart ischemia, myocardial ischemia, the goal is 0. I think that I remember this question. Correct. The goal in the pain management for the patient with acute myocardial infarction is to completely eliminate the pain. Remember that, guys. Pain should be 0 in MI. If the pain persists, those are the clients that doctors take as immediately, as emergency to cardiac catheterization. It's a very bad prognosis in myocardial infarction that the pain doesn't disappear with administration of nitro and morphine in sequence, in the expected sequence, okay? Any persistence of pain is that the infarction is expanding, is growing. Do not see the infarction like a spot in the heart that is growing, like an stain in the heart that is growing. This growth should be stopped and even reverted with reperfusion therapy when the obstructed pipe, the obstructed vessel, blood vessel, the obstructed coronary artery branch is reopened with thrombolytic therapy, with angioplastic and stent, or even with bypass, with coronary artery bypass graft. The size of the spot, the size of the stain is decreased. So the purpose of the treatment of myocardial infarction is to decrease the amount of tissue that is dying. Remember that this process of dying in, in myocardial infarction takes hours. That's why you have a time frame that for the FDA is 6 hours, but for the American Heart Association is 10 to 12 hours of chance to administer thrombolytic therapy or to do reperfusion therapy. Why? Because still you can save myocardium with doing that. But the first evidence that the process of expansion of the necrosis has been stopped is that the pain stops. The persistence of pain in MI means that the size of the MI is expanding. That's the rationale for which pain should be eliminated in a client in the acute management of myocardial infarction. Tricky question. The nurse is preparing to implement teaching about the heart healthy diet and activity level for a patient who has a myocardial infarction and the patient spouse. The patient says, I don't see why I need any teaching. I don't think I need to change anything right now. I think that I saw this question in Hessing once. Okay, the patient say, why? Don't teach me that. I don't need to change anything. I eat very healthy. Okay. I only have a hamburger 3 times per week. I only have, okay, pork ribs, okay, 2 times per week. So I eat very healthy. Which response is most appropriate? So it is a question probably of therapeutic communication. Do you think your family may want you to make some lifestyle changes? Can you tell me why you don't feel that you need to make any changes? You are still in the stage of denial, but you will want this information later on. Even though you don't want to change, it is important that you have this teaching. Okay, this is therapeutic communication. What is the most therapeutic option here?
Would it be 2, Professor?
Any other opinion? We have been number 4.
Maybe number 4. Yeah.
Okay, 2 and 4. Okay, we have been programmed because it is a conditioning, like Pavlov dog. I don't know if you know what is a Pavlov dog. You should know. Okay, and because if you don't know, I'm going to talk to Monal to scold you. Okay, you are conditioned like the Pavlov dog that when you see why to avoid these options. No?
Yes.
So, but in my experience, why sometimes need to be used?
No, and I've seen a lot of questions in eWorld, and I got questions on the last test where why was the answer.
Exactly. Okay, so we are 2. Okay, you see that? We are 2 people seeing that. Okay, so I see a lot of opportunities in why is needed. Okay, is needed. So I'd like for Nclex to decondition, to reprogram you to don't refuse option with why automatically. Sometimes is the right answer. It's just remember that my role here is trying to help you a little for your upcoming English. Okay? So don't discard options just because you are using the word why. We know that why is something that need to be used very carefully. Because is when should not be used when you are challenging somebody. Why you touch me? Why you are coming so late? Why aren't you studying? Why aren't you wearing the uniform? Okay, so this is when I want to fight with students. When I I love to fight with students. When I want to fight with a student, say, why are not wearing the uniform? Okay, and then comes the fight. Okay, so guindaron ballín y el estudiante. You know, so you don't do that with patient because you are not winning anything with a fight. Fight is not going to bring any benefit. Okay, and those are the situations where you don't use why. But sometimes you need to use why. Why you? How many times I'm asked you why you prefer one? And it's not challenging you. It's not offending you. It's just to give you the opportunity to give me your rationale, which usually is perfect. When I ask you why, it's perfect. The rationale that you are giving are perfect, you know? Okay, so between 2 and 4, therapeutic communication. Okay, let's see. Can you tell me why you don't feel that you need to make any changes? I'm attracted to 2 because give you the information that I need. Maybe the client say, hey, I'm a dietitian and I am being vegan, okay, for the last 20 years, and I'm perfectly okay aware of an atherogenic diet and what to avoid, and I perfectly know, okay, maybe when I say, can you tell me why you don't feel that you need any change in your diet? Maybe I discovered. So guys, will be embarrassing that when you are teaching the person about the diet, they say, no, I have PhD, I'm a dietitian and have a PhD in as a dietitian. It is my profession. And I'm very, very careful with my diet. I've been vegan for 20 years. So it's a little embarrassing. So I feel attracted to 2 because it's an assessment of what is in the mind of this person, you know, what is in the head of this person. Maybe the person has knowledge deficit and is the kind of people that doesn't believe that the diet is important to be healthy. It's a lot of information that I can obtain from option 2. Option 4 is reasonable, okay, but it's not giving me anything. So it's just I'm assuming that the patient will accept the information I'm delivering. It's like forcing a student to go over an explanation when they don't want to hear the explanation. So, okay, what we conclude here, that those therapeutic communication questions are more art than science, and you cannot learn that in books. You learn this just with common sense and practicing questions. So let's go to 4. Okay, they say incorrect. They say that number 2. For behavior to change, the patient must be aware of the need to make changes. So the patient need to be aware to make changes. Cannot be postponed like in this, no, for later. Okay, if you want, okay, you need this decision. This response acknowledges the patient's statement and asks for further clarification. And this is what my point, that why can be used for further clarification. This will give the nurse more information assessment about the patient's feelings, current diet, and activity levels, and may increase the willingness to learn. And especially you are going to evaluate there is knowledge deficit or not. The other responses, although possibly accurate, indicate an intention to teach whether the patient is ready or not, or are not likely to lead to changes in lifestyle. Do you agree? No? Is this the same stuff that we
Professor,
say?
number 2 was the correct one, right?
Is the correct number 2?
Yeah, I've seen this lately, you know, which originally we had that why would not be the answer, but I already changed my mind and said no.
Correct.
Aquí me un video.
Okay.
Un video.
Mute your microphone. You left the microphone open.
De enfermería. Ya. Fíjate de qué de nuevo.
Knock, knock. Okay, she's not here. The nurse is.
You have to say it.
Hello. The nurse is caring for a hospitalized patient with heart failure who is receiving captopril and spironolactone. Bad combination. You should know that it's a bad combination. And you know why, no? Which laboratory value is most important to monitor? Of course, potassium. Captopril elevates potassium. Spironolactone elevates potassium. So it's going to be raining over wet. Okay, so that's the answer. Potassium level. No doubt of that. Correct. Okay. The healthcare provider telephones the nurse with new prescription for a patient with angina who is already taking aspirin. Which medication is most important to clarify further with the healthcare provider? So the client's taking aspirin and the doctor ordered clopidogrel, ibuprofen, metoprolol, and nitroglycerin. Which one do you think is not compatible with aspirin? Obviously, this is a patient that has coronary artery disease. Clopidogrel, metoprolol, and nitroglycerins are expected medication.
Ibuprofen?
But ibuprofen is contraindicated in heart disease, client with hypertension, clients with heart failure, clients with angina or coronary artery disease, and clients with renal disease cannot take NSAIDs. Of course, also clients with ulcers and gastritis, no? So remember, NSAIDs are no in when they are contraindicated. Of course, everybody knows when there are ulcers and gastritis are contraindicated. But client with hypertension should not take NSAIDs. Client with heart failure, okay, should not take NSAIDs. Clients with coronary artery disease should not be taking NSAIDs. Increased mortality. Need to know that. Client with renal failure cannot take NSAIDs. Of course, clients allergic to NSAIDs or aspirin should not take that. Okay, the last trimester of pregnancy. In the last trimester of pregnancy, NSAIDs cannot be taken. Okay, those are the most important contraindication of the NSAID. This is a contraindication. In this client, it's a contraindication. Absolutely. Okay, NSAIDs inhibit the beneficial effect of the aspirin coronary artery disease and increase mortality. And I recommend against the use of NSAIDs in patient cardiovascular disease. The others are used in client with that. Okay, it's a reinforcement of what we already knew, no? At 10 a.m., a hospitalized patient received a new order for a transesophageal echocardiography, TEE, transesophageal echocardiogram, as soon as possible at 10 a.m. Which action probably is going to have a cardioversion? No? Which action will the nurse take first? Put the client's NPO, teach the clients about the procedure, insert an IV catheter in the patient forearms, attach the patient to a cardiac monitor. Easy question. What is the answer?
Number one?
Of course, that number one. How is done a transesophageal echocardiogram? Introducing through the mouth, the throat, and the esophagus, introducing an endoscope that has the probe of the echocardiograph. So remember that this test is required when clients are going to a, ¿cómo se llama esto? Version. Remember that the heart have the two atriums and the ventricles, but the ¿cómo se llama? The heart has like a horizontal position. The esophagus come here, okay, come here, okay, come here, and the atriums are against the esophagus. Here is the sternum, and the chest wall, okay, the chest wall, okay, the chest wall. Those are supposed to be the ribs, no? Okay, and the traditional echocardiogram is done transthoracic. Okay? The probe of the echosonogram is placed in the chest between the ribs, but It's very good to see the ventricles, but not good to see the atriums. To see the atriums, the doctor most ¿cómo se llama? Most introduce an endoscope through the mouth, and then from the endoscope is doing the echocardiograph, okay, of the atrium through the esophagus. It's called TEE, transesophageal echocardiogram. Of course, it is an invasive procedure that requires consent. The patient needs to be MPO, is an endoscopy, guys. Is going to have anesthesia, local anesthesia in spray in the throat. For that reason, the gag reflex and the coughing reflex and all those reflexes are going to be inhibited. So the client, after the TEE, cannot eat or drink until the gag reflex is verified that has returned, when the local anesthesia has worn out. And yes, MPO, and the patient is sedated, so the patient cannot drive home. If the client is ambulatory, ¿cómo se llama? Cannot drive home. Okay, so remember the TEE equals endoscopy. Okay, endoscopy. Okay. The TEE is frequently done when the client is going to have a cardioversion because he's having, for example, atrial fibrillation. Remember that in atrial fibrillation, there are tendency to form clots in the atriums. The cardioversion cannot be done if there are still clots in the atriums. That's why those clients need to be placed in anticoagulants until those clots are dissolved spontaneously by the natural mechanism of thrombolysis. Echocardiogram is the transesophageal echocardiogram is necessary before a cardioversion, an elective cardioversion. Cardioversion is this electrical shock synchronized that is used to treat supraventricular dysrhythmias like atrial fibrillation. Okay. So MPO. Absolutely. MPO. A patient with a stable angina has a prescription for ranolazine. My goodness, ranolazine. Ranolazine is a not common medication. Let's go to Hippocrates. Let's come. Oh, let's go to drugs. Ranolazine. Ranexacine. What's wrong with you, Hippocrates? Okay, ranolazine. Ranolazine, Ranexa. Oh, caramba, no me deja entrar. Bien, déjame entrar. Okay. It is, I don't know what happened that it doesn't allow me to enter. Hippocrates online login. It's not working. ¿Será que tengo algún bloqueo? Maybe it's not working today. Okay. Okay, it is a medication using in ischemic heart disease, Ranexa. Of the group of the anti-anginal medication is a family of the calcium channel blockers, similar to the calcium channel blockers. And it's an anti-anginal anti-ischemic medication. It's a really cross. Okay, the long acting. Remember the long acting. Because as all the calcium channel blockers should not be taken with grapefruit. Of course, lowers the blood pressure. Okay, yeah, I remember. It's not very commonly used. Case. Okay, so the patient angina is prescribed ranolazine 500 milligrams twice daily. Which patient finding is most important for the nurse to discuss with the healthcare provider? Heart rate is 52. Patient, but it's not a beta blocker. Patient is also taking carvedilol for angina. That's why the heart rate. Patient report having chronic constipation. Blood pressure is blood pressure is normal. I rule out this. There is no contraindication. I already told you 90. Okay. The heart rate, but as far as I know, ranolazine doesn't affect heart rate. Patient is also taking carvedilol. Is commonly combined with beta blockers. So I can rule out this. I can rule out this. It's between 1 and 3, but I don't remember that is. Okay, let's put the heartbeats. Like what they say, incorrect. The answer is patient report having chronic constipation. Chronic constipation is a common adverse effect of ranolazine. Ranolazine does not impact heart rate or blood pressure and can be taken with beta blocker or nitrate. I usually see ranolazine given with the beta blocker. The other information must report. Guys, sometimes you need to give a question and you get a educated guess. Ranolazine is not a medication that I think is going to be in your Nclex. Okay, so remember that if in your Nclex probably it's not graded. So remember, sometimes you need to give up some medication, some question because you are not familiar with the medication. This is another teaching that the fact that in one moment in your test you notice that you have a couple of questions that you don't know the medication or the situation, trying to do an educated guess and move on. Doesn't mean that you're going to fail. It is okay to fail some questions like this. Okay, so it is a teaching. Ranolazine produces constipation, very nice to know, but it's not life or death, okay, situation. The nurse assesses a patient who has just returned to the recovery area after undergoing coronary arteriography. Okay, so it's coming after coronary arteriography. So in 2 words, they have a cardiac catheterization because to do a coronary arteriography, you need to enter in the femoral artery in the groin, go up through the aorta until reaching the root of the aorta where the coronary arteries originate. Okay, and has just returned to the recovery area. Okay, after this procedure, what information is most concerned? What is more concerning? Blood pressure is a little high, not critically high. Pedal pulses are palpable, are 1+. Left groin has a 3 centimeters bruise area. Apical pulse is 122 per minute and regular. What do you think? What do you think, guys? What strategy? How do you deal with this question? Let me see how you're thinking.
Between the number 1 and number 4.
Number 1 and number 4.
Correct.
Okay. This is not an emergency. This blood pressure. Okay, this is not an hypertensive emergency. So it is a systolic, mild, okay, hypertension. Remember that until 160 over 100, 160, 160, 100 is mild hypertension. Okay, so it's a mild hypertension. It is not an emergency. Having the blood pressure high, moderately high, in one moment is not critical. What about this? Patient has a cardiac catheterization. Okay, this is a client with cardiac catheterization.
Yeah, that one
Yeah,
is
that one.
concerning, yes.
But you know what is the trap of this auction? Is bilateral, and they did the cardiac catheterization in only one leg. So it looks that it is probably an old patient with history of smoking, high cholesterol, etc. That's why it ended in cardiac catheterization. And both legs have pulse, but equally, symmetrically, plural decrease in both. So it
And
is a trap.
expected, correct?
It is exactly, it's expected. It is not. If they say in the leg of the procedure is 1 plus and the other leg is 2 plus, okay, now this is the stuff. But this is a trap, and they use this trap a lot. Remember, we need to be checking for intensity and presence of pulse, presence and intensity of the pulses in the lower extremities comparatively. Yeah, because if the pulse is weak in comparison with the other legs, this is concerning. But if both legs have weak pulses, 1 plus, present but weak, is because the client has previous to the catheterization peripheral arterial disease in the lower extremities, which is very common. Is very common in clients that requires going for cardiac catheterization. So this is a common trap, a common trick in cardiac catheterization question. Could be in Nclex, yes, could be. Why? Because it's so frequent. Who goes for a cardiac catheterization? A young person that never smoked and never has high cholesterol, never have diabetes. No, are all people that are diabetic, are a smoker or ex-smoker, high cholesterol, that have obstructed the coronaries, but also obstructed the arteries of both lower extremities, have peripheral arterial disease. So that's why if it is symmetrical, it is bilateral, okay? That's why they say pedal pulses are plural, no? Plural are two legs, no? 1 plus because it's symmetrical. So it is a trap, it's not 2. It's not 1, it's not 2. 1 is okay, 1 is perfect. This blood pressure is perfect. So the bruise, well, you expect a bruise. I said that at the beginning. They make an incision and a puncture in the groin, in the femoral vein. So you expect some bruising. 3 centimeters is a 1.5 inch. It's a small bruise. It's expected. Bad would be a lump. If you see a lump, okay, a ball there, or it could be a big hematoma building up under the skin, because the skin is going to be closed with stitches or staples, yes, tightly closed, and the blood could be building up under the skin, forming a lump. It could be a question your ankles. You find, instead of a bruise, you find a lump. You know, oh, okay, this is a hematoma. It is bigger. Or you see blood coming out. You know, the patient has a soaked dressing, or there is blood behind the body, between the clients and the mattress. I mean, behind the butt. No. So I think that the most probably is the 4. Why? Because it's not expected this tachycardia in a patient, that just had this procedure. This is a tachycardia. Why this tachycardia? So let's guess. Okay, they say that yes, it's the tachycardia. The most common complication of the coronary arteriography is hemorrhage, and the earliest indication of hemorrhage is an increased heart rate. Okay, hemorrhage, and what is the blood? The other data may also indicate a need for ongoing assessment, but the increasing heart rate is the most concerning. I don't like the question, but I don't like the rationale. The question is good. The question is acceptable, but I don't like the rationale. Okay. Summarizing, this blood pressure is not concerning. Okay. A finding of a blood pressure 160 over 100 randomly is not concerning. It's not an emergency.
Professor,
Bilateral
I
pulses.
disagree. I disagree with that rationale because the options that they are providing, like for example, that blood pressure is not an indication of
Compatible with
any hemorrhage,
bleeding. Yes.
and
This is okay.
pulse is not an indication, so that's completely off.
Okay, but let's ignore ignore this rationale. But what we learn here, a strategy that we didn't know exactly the answer to this question, but we were sure that this blood pressure is not an emergency, and they are asking for the emergency, the most concerning. So for those that are ¿cómo se llama? Too concerned when the blood pressure is a little high, it's not an emergency. High blood pressure at this level below 160 over 100 is not concerning. It's not concerning. It is not an issue. The same as the blood pressure above 90 over 60 when it tends to be low. So have those limits for test purposes for blood pressure as not priority. I mean, 160 over 100 as the upper limit and 90 over 60 for the lower limit. So I think that it could help to eliminate distractors. We already discussed this and we learned that. And the bruise have been already discussed. And I gave you the other options, finding blood coming out or finding a lump. Okay, in the job, but it's not. Okay, so need to be by ruling. I'm pretty sure this is not need to be this, because this is not normal. You need to find out what is the reason of this. Is the patient in pain? Could be a reason. Is the patient, usually those patients are sedated, no? But is the patient with anxiety? You need to find out. Is the patient having fever because it's developing a neuroleptic malignant syndrome? It's not usual with the type of the procedure, but maybe. Is the patient having, qué sé yo, pulmonary embolism? Is the patient having, qué sé yo, and also, I don't know, a dysrhythmia, an acute atrial fibrillation, even if the pulse phase is regular, but it's a possibility. Okay, a flutter can give a regular pulse. Okay, so you need to find out what is that. The rationale is lousy, but definitively the answer, I agree with the answer key, not with the rationale. Good. Nurses working in an outpatient clinic where many vascular diagnostic tests are performed. Which task associated with vascular testing is most appropriate to delegate to the experienced CNA? I'm sorry, I use CNA because I work as a CNA. I'm certified nurse assistant. I work as a CNA. I did my training in my test. By the way, for your information, I don't know, probably you already told you that the test, at least in my times when I started working as CNA, the test for CNA is more stressing than the NCLEX. There are two tests, usually in 2 different days. One day is a knowledge test, it's a written test, 100 questions. I remember 100 questions, a written test, and a lot of information to know. And the next day is a practical test, very stressing, okay, where they make you do a lot of procedure and they are observing you to see if you commit a mistake. Okay, so it was very, very stressing. I never felt stress or too stress in my English or my nursing school test. Okay, even in Robert Morgan, where the nurses were very strict, extremely, terribly strict. Okay, but never felt okay stressed. But I remember being very stressed the day of the test of the
It
CNA.
is.
It
It
is
is.
okay. So somebody that can support me there. Okay, a
Yeah,
little.
I took my in 2009. Was stressful.
It was very stressful. Yes, I
Yeah.
remember that at that time was not done in date. I need to go to Broward,
And I didn't
and
speak English very well. It was stressful.
very stressful. I remember that it was an old white American, all white American nurse. Those all school nurses. Okay, with
Yeah.
a little obese, ugly, and you know, cranky face. My goodness, she was observing everything and writing everything and writing everything and writing. They made me wash my hand. They made me change a
The best.
occupied bed. They made me do range of motion, a lot of joints.
Yeah.
They, oh my goodness, they make me to administer an enema to a mannequin. Oh Lord, everything, everything, and they were to not observing me. They didn't speak anything. They didn't mention anything.
Nope.
No, they didn't give you any
Mm-mm.
feedback. At the end, I was
They
crushed,
took it
guys.
to
I'm
pass on that.
shaking at the end. And then you pass. Okay. Oh
Yeah.
my goodness. I remember that we worked that day like probably like 15 people. I remember that only 2 passed of 15.
Yeah.
Only 2 passed. The majority, of course, worked like me, Hispanic, and English was an issue. But again, 15 2 passed. Only 2 passed. But were other times. Okay. A little break. The nurses working in a patient clinic, many vascular diagnosis are performed, and must apply delegate to the CNA. Measuring ankle and brachial pressures in a patient for whom the ankle brachial index is to be calculated. Could be. Checking blood pressure and pulse every 10 minutes in a patient who is undergoing exercise testing. No. The client is undergoing a stress test, and the patient needs to be tightly monitored. Vital signs, respiration, O2 saturation. You saw what happens with all those parameters during exercise. The EKG and the chest sensation. This kind of stuff need to be done by the RN. And an RN trained, specialized in stress test. So definitively no. Why? Because the client is undergoing. So continuous present, happening right now. A stress test. Definitively no. Obtaining information about allergy, no, it is assessment. Easy, no? Obtaining information about allergy in the patient, no, it is assessment. Providing brief teaching, no, okay, so need to be one. Need to be one. So what is that? Guys, the blood pressure in the lower extremities can be measured with a automatic blood pressure cuff. Okay, with automatic blood pressure cuff. Uh, okay, can be measured above the ankle and with an automatic blood pressure cuff, and can be measured in the arm. And the nurse, not the CNA. The CNA only reports those 2 blood pressures. ¿Cómo se llama? The RN will do a, ¿cómo se llama eso? Calculation, a calculation called ankle brachial index. Normally, the blood pressure in the lower extremities, I mean in the ankle, is slightly higher than in the arm. It's just because the gravity force. okay, the blood pressure in your legs must be higher in your legs than in your arms. Not too much, but a little. So maybe in your ankle, you have 128. And maybe this is systolic. You take this systolic. And maybe in their arm, so the brachial is 120. You see that is higher in the ankle. Of course, whatever the number is going to be more than one, because when the numerator is bigger than the denominator, when you do the index, when you make the division, must be more than one point something. If the client has bad circulation in the legs, which is a common disease called peripheral arterial disease, is going to be inverted. So now the blood pressure in the legs is going to be lower than in the arm. So it's going to be 100 in the legs, in the ankle, and higher in the brachial. So now it inverts. It's going to the ankle brachial index is going to be less than 1. I like you to know that this ankle brachial index can be done by the RN. It's a procedure, it's very simple. You measure the systolic blood pressure in the arm and the systolic blood pressure in the legs. You can send the CNA to do that, and then you do the division. Ankle in the top, brachial in the top to make a division, an index, and should be the normal. The normal for you and me is more than 1, because always the ankle should be a little higher and is the numerator than the brachial. This is the ankle brachial index. Is one day you have something to do with that. Frequently done to diagnose peripheral arterial disease. So 1 is okay. Okay, they agree with me. Definitively. The others are not in the scope of practice CNA. While working on the cardiac step-down unit, the nurse is precepting. Preceptor is the nurse that is teaching us, or is when we rotate in clinicals, when a nurse takes us and helps us to pass medication, etc. Is precepting a newly graduated registered nurse who has been in a 6-week orientation program. Which patient will be best to be assigned to the new graduate? So again, it's more similar to the criteria for the floating nurse. Give a stable client and something that a new graduate nurse can do. Okay, a 19-year-old patient with rheumatic fever who needs discharge teaching before going home with a roommate today. I think this is too complicated. Discharge teaching is too complex to be delegated. 33 years old patient admitted a week ago with endocarditis. So weak with endocarditis, and is receiving ceftriaxone 2-gram IV. A new graduate nurse should know how to administer that. It is a stable client, has already 1 week, okay, admitted 1 week, has been in the hospital for 1 week, so it's already let's see, stable, no? Is already stable. And just IV antibiotics. A 50 years old patient with newly diagnosed stable angina who has many questions about many questions. No. A 75-old patient who has just been you see this word, just admitted, just received transfer from the unit. So definitively the client that requires antibiotic. Let's see. Exactly. Remember that this book is specialized in prioritization and delegation, which is a super important component of your English. Is within the area of management. That is the heaviest part of your test. The nurse is monitoring the cardiac rhythm of patients in the coronary care unit. Which patient will need immediate intervention? 1. Patient admitted with heart failure who has atrial fibrillation with a rate of 88 beats per minute while at rest. Okay, the problem with atrial fibrillation is when has tachycardia, frequently have a tachycardia, and for that reason requires medication to lower the heart rate, beta blockers, calcium channel blockers, etc. This heart rate is normal, so this is not a priority. Patient with a newly implanted demand ventricular pacemaker, so has a ventricular pacemaker at demand, who has occasional periods of sinus rhythm at a rate of 900 to 9 to 100 beats per minute. It's okay. The clients with demand pacemaker, the pacemaker is not all time working. When the clients can produce a sinus rhythm, the pacemaker turn off, inhibits. And for that reason, you can find sinus rhythm in those clients. It is normal. So I rule out this. Patient who has had an acute myocardial infarction and has sinus rhythm at a rate of 76 beats per minute with frequent PVCs. This is not good. I already told you. Clients with ischemic heart disease and PVCs is not a good combination. Those are the PVCs that can be frequent, can be coming in in pairs or triplets, or can have the R on T phenomenon and can precipitate a VTAC or a ventricular fibrillation. This is not a good combination. I'm concerned about this client, but always read all of the options. Patient who recently started taking atenolol and has a first-degree heart block. Okay, the first-degree heart block are just observed, doesn't require intervention. AB blocks are classified in 1, 2, and 3 degree. So first, second, and third degree. The first degree heart block are asymptomatic and thus only require observation, doesn't need any kind of intervention. And clients taking beta blockers as far as the heart rate is above 50, it is acceptable. So I'm pretty sure that the client with the PVCs is the most critical. Yeah. Premature ventricular contraction occurring in the setting of acute myocardial injury or infarction can lead to ventricular tachycardia, ventricular fibrillation, cardiac arrest. So rapid treatment is necessary. Remember that they use lidocaine or amiodarone. Lidocaine is an anesthetic. I think the last week, one of your fellows connected to comment what she saw in her anchors, and she commented that she had which kind of medication was expected to be ordered in a client with PVC. And she mentioned something about anesthetics. So we say that it is or lidocaine or procainamide that are the two anesthetic-related medication used for the treatment of ventricular dysrhythmia. Yeah, okay. So it could be a question. Okay, this is, remember, PVCs and ischemia is no good. Also, PVCs with alteration of the potassium is no good, or PVCs inclined with ditch toxicity, with digitalis toxicity is no good, but especially clients that are ischemic. Patient in the emergency department who is being monitored with a portable cardiac monitor, defibrillator. Okay, the patient has a portable cardiac defibrillator. Develop this rhythm, see the figure. It is a ventricular fibrillation. You can recognize this is the B-fib, no? Ventricular fibrillation. You see this totally chaotic rhythm. It is, there is not any kind of morphology. They are a part of a shaking, there, vibration there. Which action will be taken first? We have defibrillate at 200 joules, start cardiopulmonary resuscitation, CPR, basically chest compression, amidst epinephrine. Epinephrine is not indicated in ventricular fibrillation. Intubate and manually ventilate. Remember that in cardiac arrest, we don't take care of the airway and respiration until the circulation has been taken care. So what you do, you start chest compression or you defibrillate. Notice the detail. The client is carrying a portable defibrillator, which makes this question special. It's not the usual. The usual is not this. The usual is that you find a client on the floor and you, como se llama, don't find a response and you don't find pulse, and for that reason you start chest compression. But
No,
you don't have, the defibrillator. In this case, it's an atypical client. It's
well,
carrying a monitor and a defibrillator. What you do first?
since that patient already have the defibrillator and it's
You are
already
witnessing, and you are witnessing is the word. The term is you are witnessing the beginning of the ventricular fibrillation. What you do?
you defibrillate, right?
You defibrillate.
Yeah, you're not gonna start resuscitation or anything
Okay.
like that.
Guys, in the real life, the real scenario, 99.99% of the cases, the client is not carrying a portable defibrillator. Okay. And for that reason, it's very rare, this situation. The American Heart Association, in their protocol, which is a very complete, protocol of cardiopulmonary resuscitation, comments about this, that the usual scenario is that you don't have available a defibrillator when the client is diagnosed to be in ventricular fibrillation. For that reason, they said the evidence says that it's better to initiate chest compression at least 2 cycles. You know that each cycle are 30 chest compression, 2 respiration. No? At least 2 cycles of TPR, chest compression and ventilation, increases the probability that when the client receives the electrical shock, the rhythm is controlled. So the outcome, the desired return to normal rhythm after electrical shock increases if the client has already received 2 cycles of compressions and ventilation. But they say, in the extremely rare circumstances that you are witnessing, so you are looking because you don't have anything else to do, you are looking to the monitor and you observe, you are witnessing the beginning, the sudden beginning of a ventricular fibrillation, and you have available at the bedside, immediately available a defibrillator, in that case is better to deliver immediately, even before giving chest compressions and the resuscitation, etc., delivering a electrical shock, so a defibrillation. But as I said, they say that, and my experience is the real life, it's very rare that this perfect scenario is a coincident. Okay, everything is coincident. There are other circumstances are coincident there that you can do that. So yes, this is a common question. Let's see. Exactly. It is a common question. In the case that you in the question are witnessing the beginning of the ventricular fibrillation and you have available a, a defibrillator, you can first deliver the defibrillation. But this is not the usual scenario. The usual scenario is one, you are walking or the CNA calls you and because there is a client found unresponsive on bed, in the bathroom, in bed, in the bathroom, or on the floor. What you do first, check for responsiveness. Sir, what happened? Sir, are you okay? So check for responsiveness. Okay, the client doesn't respond, call a code. Ask for help. This is the sequence. So what you do first, check for responsiveness. No response, second step, call for help. Call a code. Third step, check carotid pulse. Okay, before checking for carotid pulse, if the client is not responsive, you call for code. So check for responsiveness. Second, call the code. I told you 3 times, so you're clear. In the usual circumstance that you find the clients, that you think is could be in cardiac arrest. So the third is to check for pulse. No pulse, start chest compression and wait for the people to arrive with the crash cart and the defibrillator, etc., and then everything is going to be done. In the case that you hear, okay, an alarm, and you go and you see in the monitor a ventricular fibrillation, call the code, and okay, you don't have in this scenario the defibrillator. You just have a client with a monitor. Not all the clients have the defibrillator at the bedside, and it's not profitable to have a defibrillator at the bedside of all the clients. Okay, so you wait for the defibrillator to come. Meanwhile, you keep the clients alive with chest compression. But if the scenario is a client that has a defibrillator available and you are witnessing the beginning of the ventricular fibrillation, then it is indicated to defibrillate before doing chest compression. By the way, another topic: when you defibrillate, you deliver the shock, and you obtain a sinus rhythm, so you convert the fibrillation into a sinus rhythm, you need to give 2 cycles at least 2 cycles of chest compression. Because when you see in the monitor the normalization of the electrical rhythm, still the blood is not moving. The electrical normalization of the rhythm in the monitor doesn't imply that the heart that now is electrically okay, normal, is moving the blood. You need to help the client at least with 2 cycles of chest compression. This is the protocol. Why? Because the heart has been for some period of time, for some seconds or minutes, without a good perfusion, and is still weak, is still acidotic, is still hypoxic, and requires help to move the blood. That's why we need to do 2 cycles of chest compression after the client returns to a normal sinus rhythm with a defibrillation. Those are interesting topics that sadly, I can assure you, Nclex is exigent, is demanding in CPR. You need to have, a basic good knowledge of CPR. It's like infection control. It's like management. Nclex requires, a mastering, those areas. Let's see this. 2 weeks ago, a patient with heart failure received a new prescription of carvedilol, a beta blocker, 12.5 milligrams orally, which finding by the nurse who is evaluating the patients in the cardiology clinic is most concerning. Report of increased fatigue and activity intolerance. It is very common in beta blockers. Weight increase of half a kilo over, so 1 pound over 1 week is okay. It is not the critical increment. 2 to 3 pounds. 1 to 1.5 kilo in 1 week is what they the limit that they give us of concerning of fluid retention. It is okay. Even if you weigh, I don't know if it happened to you, but if you weigh in the morning and then you weigh in the afternoon, you notice that you gain like a pound or pound and a half, okay, during the day. Okay, it's okay, it is normal. Sinus bradycardia at 48 is too low, less than 50. Sinus bradycardia at 48 is too low, less than 50. You remember the limit of 50 that I gave you, at least for test purposes. Traces of edema, traces is minimum of edema noticed in both ankles, and the client is already diagnosed with heart failure. So what do you think? I think that is 3. Do you agree?
Yes.
Yes.
Okay, let's mark. Okay, we are right. So 48 is too low. It's too low. Beta blockers. Yes, yes.
I'm sorry, I have a question. Is the patient is presenting, like, if we take it daily metoprolol, for example, presenting a 52 heart rate, do you hold that metoprolol?
No,
Like,
no,
we
no.
always
You need to talk to the doctor, because usually they accept above 55 as as acceptable in patient taking beta blockers, especially they are for ischemia.
Okay.
It's a common reason for crash between doctors and nurses. Okay, because doctors want to keep the clients below 60 for several reasons, but above 50. Meanwhile, the client is asymptomatic. And then nurses have been, a program, condition, like the Pavlov dog, that below 60 is an issue. And you need to know if the client is receiving beta blocker, not dioxin. It doesn't apply to dioxin, only for beta blockers, all, okay? They want a heart rate, okay, above 50, not necessarily above 60. Okay, it depends on the, is individualized, but they consider unacceptable below 50. 50 is or less is unacceptable, but having a client with 52, 53, 55 is perfectly frequently the desired target of many clients, not all, but many clients. But definitively here we don't have this problem. 48 is below 50.
Okay, perfect.
The nurse has just received a change of shift report about these patients on the coronary step down unit. Which one will the nurse assess first? They say a 26-year-old patient with heart failure caused by congenital mitral stenosis who is scheduled for balloon valvuloplasty later today. Okay, this patient is stable. Guys, this is the other valve that tends to have problems, a part of the aorta. You remember that today we talk about the aortic stenosis, yes. Okay, the mitral stenosis is the other one that is frequent. But in the case of the aortic stenosis, it's usually old people. The narrowing, okay, the narrowing of the aorta is, the aortic stenosis is because, aging, fibrosis, and calcification of the aortic valve requiring the replacement with the mechanical or biological valve. You remember? Okay, the other one that can have problem is the mitral valve. But in the case of the mitral valve, generally, the problem is rheumatic fever. Rheumatic fever is this inflammation that can occur in the heart as an immunological phenomenon after an strep throat, amygdalitis, tonsillitis, okay? A strep throat, yeah. And it can produce mitral stenosis. So you see the mitral stenosis more frequently in younger people. In this case, they say it was congenital, which is not very common. But what the nurse that who wrote to this question said it's congenital. Mitral stenosis is very rare. congenital mitral stenosis. It's not a common malformation, but could be. Whatever, this is not the problem. The problem, the patient have mitral stenosis. Of course, it is going to produce a building up of blood in the left atrium that backflows to the lungs, producing left heart failure. Yes. Nevertheless, the patient is going to have an elective, not emergency, elective surgery today. It's a wonderful surgery in which there is no need of replacement. They introduce by catheterization, they introduce a catheter with a balloon in the valve, and they inflate the balloon and enlarge, expand, enlarge the valve, opening a space for the blood to flow and reducing the narrowing, reducing the stenosis. So I just wanted to comment what is this, but it is not emergency. And they are asking who you see first. It's going to have that later, so it's just preparation. A 45 years old patient with constrictive cardiomyopathy. Cardiomyopathy is a group of diseases that affects the myocardium. And there are several types, are not common, but are very, very, very bad diseases that ends in cardiac transplant. There is a variety that is called constrictive. Okay, there is a fibrosis of the left ventricle that is, it shrinks the ventricle and decreases the diastolic capacity of filling with blood, and it's very bad. Who develop acute dyspnea? No good. Acute dyspnea is no good. And agitation because the brain is not receiving oxygen 1 hour before the shift change. It is concerning.
For me, it's between that one and the last one.
Okay, let me resolve. You are fast, but you know what? Was another group of students that have been saying. Given their point of view of what they did as a strategy during the test, and an agreement as being don't rush. Don't procrastinate, but don't rush. Okay, so trying to understand what. Okay, a 56-year-old patient who underwent coronary angioplasty, so already had coronary angioplasty and a stent placement yesterday, so 24 hours later, and has reported occasional, this is expected. Okay, it is expected, occasional chest pain. A 77-year-old patient who was transferred from the ICU 2 days ago, isn't a step down? See, a step down unit, yes. 2 days ago was transferred from the ICU to the step down unit after coronary artery bypass grafting and has a temperature of low-grade fever. For your information, this kind of surgery, the CABG, the coronary artery bypass graft, frequently produces inflammation in the pericardium. And so a non-infectious pericarditis. And for that reason, can produce low-grade fever, okay? Low-grade fever. Okay, so that's why this fever is reported low, okay? Is reported as a low-grade fever. So for ABCs, airway, breathing, and circulation, having a client with acute dyspnea and a client with a low-grade fever that probably is consequences of the type of surgery that is frequently seen, obviously, you need to choose two. For ABC, breathing and oxygenation is the priority. So is ABCs useful in NCLEX? Absolutely yes. I support ABCs as a wonderful strategy to decide when you are between two options in NCLEX. I love expected versus non-expected and ABC as an strategy when I am left between two options. Has been so useful. Next, the charge nurse in long-term care facility that employs RN, LPNs, and assisted personnel have developed a plan for the ongoing assessment of all residents with a diagnosis of heart failure. Which activity included in the plan is most appropriate to assign to an LPN? What can do an LPN? They say in the ongoing assessment, LPN can do ongoing assessment. Let's see. Weighing all residents with heart failure each morning. It should be done by the CNA. They have, yes, okay, they can be done by the CNA. Don't put the LPN, sorry, case, no sé. Don't put the CNA to do this. Don't put pardon, sorry, I apologize. Don't put the LPN to do what the CNA can do, the UAP can do. Listening to long sounds and checking for edema each week, it can be done by the LPN. You say, it is assessment, it's assessment. No, only a ring. No, senor. This is ongoing assessment. LPNs can do assessment of long sounds, edema assessment, apical pulse, and all this ongoing assessment to see if the client is evolving, okay, as expected. Reviewing all heart failure medication with resident every month. No, this is more a teaching activity and a reconciliation of medication. It's called reconciliation medication, where you see if these are redundance in any prescribed medications, etc., or interactions, etc. This is RN, definitively. And of course, include teaching. Updating activity plans. No, activity plan for residents is care plan, and it is for RN. Definitively, the ongoing assessment of lung sounds and edema and manifestation of heart failure in the client that have been hospitalized, to notice if there is any problem and report the problem to the RN, is in the scope of practice of LPN. Remember that this is the best proof that ongoing assessment, no initial, no assessment that is going to bring as a consequence a diagnosis. For the ongoing assessment of client already diagnosed, it is in the scope of practice of LPN. LPN education and scope of practice includes data collection, such as listening long sounds and checking for peripheral edema when caring for a stable patient. Weighing the resident should be delegated to the CNA. Reviewing medication with residents and planning appropriate activity levels are more than RN, definitively. You learn a lot of delegation with this book. I insist in recommending this book. The nurse is participating as a team member in the resuscitation of a patient who has experienced a cardiac arrest. The healthcare provider who is directing the resuscitation asks the nurse to administer epinephrine 1 milligrams IV. So they are resuscitating a client, and the doctor say, give epinephrine 1 milligrams IV. After giving the medication, with action should the nurse take next? Next is the same as first. Yes? What you do first after you inject the medication. Prepare to defibrillate the patient. Offer to take over chest compression. You know that you need to rotate because it's very extenuating. You need to offer to alternate the people that are doing the chest compression. State epinephrine 1 milligrams has been given. Continue to monitor the patient responsibly. What you answer?
I'll say 3.
Of course, the 3. So it is stated, the doctors know and the people know that the epinephrine was given. Absolutely. The American Heart Association recommends closed loop communication between team members who are involved in resuscitation of a patient. Okay, closed loop communication. Okay, the other action may also be needed, but the initial action, the first to do after administering medication, is to ensure that the team leader knows that the prescribed medication has been administered. I never heard before this term. I like to memorize that for me because I know that English love this kind of terminology. They are not necessary to understand the question or to decide the answer. But when the students have this kind of terminology in questions, they becomes a little anxious when they don't know what they mean. And makes sense. The term closed loop communication, in this member of the resuscitation team, which is a very intimate loop of people that are around the clients. When an order is given, you carry out the order and report immediately that has been carried out. It makes sense to call that closed loop communication. Okay, guys, this is what I have for you today. Okay, we are left in 33. Okay, can be no. So it's just an opportunity to recommend this book that is in at your. I know, guys. I know that you are too many books to to study now, but it's a book that I recommend at least when you leave the school. If you have not yet left the school, when you leave the school and you don't have all those assignments and those kind of stuff that you need to do, to consider doing, because it's in a small book. Fíjate that we almost finish in this time, even if I waste a lot of time talking and explaining. It's a book that you can do very fast, and it's going book that is going to help you a lot. I seriously recommend doing the La Charity book, the La Charity book, um, uh, in your preparation for your English. Okay. Where am I? Just me on the way. Okay, so I need to call the attendance. Any question, guys?
No, Professor. Thank you very much.
No,
Okay, so download the attendance list. That's it. And we'll see you next time to see what we can do.
thank you.
Bye-bye.
Thank you.
Thank you.